Hello, I'm Dr. Diana Chavkin here at SCRC Fertility in Beverly Hills, Los Angeles. So excited to be doing an IG Live here. May is Women's Health Month, and so I wanted to take this opportunity to talk about the menstrual cycle. It sounds so basic, and it kind of is, but it's really amazing, and it's actually obviously at the core of what we do as fertility doctors. And it's also, I just think, just such a fascinating thing for women to kind of hear again, although, you know, potentially everyone learns this in high school and college, but I think as we get older, we kind of forget it, and then we go on with our lives, and then sometimes when we're reminded of it, it's really fascinating. And the menstrual cycle is also, for women, it's really a barometer of our health. You know, if we are too thin or too overweight or not eating properly or extra stressed, well, we can sort of see that in our menstrual cycles, and that menses can skip, they can become longer, and so sometimes health issues can be, some of the first signs of some developing health issues can be seen in changes in our menstrual cycle. So it's important we understand our menstrual cycle. And so I'm going to kind of go over the basics here. And I know for a lot of people this is going to be a review, but for some people it may not be. So this, I can't really see so well, but I wanted to sort of bring your attention to the menstrual cycle. This is actually a diagram I often show my patients during their consultation. So up here, this is basically the course of a month, and up here are the developing follicles. So follicles are the pockets of fluid that contain the microscopic eggs, and within each follicle there are a number of eggs. So these are the follicles. This is what's happening at the level of the uterus over the course of the month. This is what's happening with the hormones. So this is I'm reading backwards here. This is FSH and LH, and these are the hormones that are secreted by the brain. And these are also hormones, and these are the hormones that are secreted by the ovaries, so estrogen and progesterone. And so essentially what's happening during the menstrual cycle over and over and over again, over the usually 28 to 30 day course of time, is that there is something happening at the level of the ovaries with the follicles and the eggs. There's something happening at the level of the uterus, and then there's something happening with the hormones from the brain and the hormones from the ovaries. And all of this interacts to help it go, to help it function. So what happens is at the beginning of the month, the beginning of the cycle, so in the first few days of a woman's period, what's happening at the level of the ovaries is that she has a number of follicles, a number of eggs that are kind of sitting there in the ovary waiting to get recruited. And what happens is that the brain is secreting these hormones, so FSH and LH, to stimulate the follicles. What happens is that one follicle becomes dominant. So one follicle kind of wins the race. The other follicles die out. So every month there's a crop that kind of get recruited, get stimulated by these hormones from the brain. One follicle, one egg gets recruited, and the other ones die off. So what happens with that recruited follicle or that recruited egg? Well, what happens is in the middle of the cycle, the follicle ruptures and releases the egg, okay? And then the egg gets picked up by the fallopian tube. If it meets sperm in the fallopian tube, pregnancy occurs. If it doesn't meet sperm, then what happens is what's happening at the level of the uterus, right? So here we see the lining thickening at the time of ovulation, and then goes up, 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 up. But then 2 weeks after ovulation, if a signal is sent that there is no pregnancy, that there is no implantation, well, then the period occurs, right? So that's what happens. That's basically what a period is. It's basically the body getting ready for pregnancy every month, right? So with the release of a follicle, by signals from the brain hormones, thickening up of the uterus, the follicle gets released, ovulation occurs, gets picked up by the fallopian tube. If it gets picked up by the fallopian tube, and then fertilization occurs in the fallopian tube, there's implantation in the uterus, well, then the uterus houses that embryo and you don't get a period. But again, if there is no implantation of that embryo, then what happens? The lining of the uterus sheds, and that's what the bleeding is in menses. And this is what's happening again, the hormones in the brain, and then these are the hormones from the ovaries. So what happens at the beginning of the menstrual cycle, progesterone is low, and then at ovulation, I see that here. So with ovulation, so with the LH surge from the brain, the second half of the cycle, there is elevation of progesterone. And then again, that kind of creeps down if there's no implantation, and then it all just starts over again. And every month that happens. And what you should know is that when a woman is on birth control pills, and this often comes up a lot with my patients, they say, well, yeah, I have a regular period, but I'm on birth control pills. And what you have to understand is that when a woman is on birth control pills, essentially what's happening is she's taking estrogen and progesterone that's inhibiting all of this from happening. It's actually inhibiting, taking higher levels, so that's inhibiting the LH and FSH from recruiting a follicle. So what's happening at the level of the ovary is not this during birth control pills, whether she's getting a period or not. Because what's happening is the follicles in the eggs are suppressed. The lining builds up because of the estrogen and progesterone, but essentially when she stops that estrogen and progesterone, which is what happens when you take that placebo week, is that the lining just sheds. And again, this interesting stuff that happens during the normal course of a normal menstrual cycle does not happen while you're taking birth control pills. There's not this fluctuation of estrogen and progesterone the way we see here. It's essentially a flat line. This is a flat line, this is a flat line. This thickens up due to the estrogen and progesterone in the pills, but then once you stop, it sloughs off. And again, the follicles don't get recruited. So just wanted to kind of bring on that point that the menstrual cycle is really a magnificent interplay between what happens at the level of the ovary, at the level of the uterus, at the level of the hormones in the brain and the hormones in the ovary, and everything kind of interacting and sending signals to one another for this to happen every month. And right, again, if we're, overweight or underweight, or we're stressed, or, a number of health issues can potentially affect the ability of the brain's hormones to be signaling correctly, and for the ability to recruit follicles. And so menstrual cycles can be altered. One of the most common reasons why women have irregular menses and what's called anovulation, so they are not ovulating, is polycystic ovary syndrome. So polycystic ovary syndrome consists of a number of things, but one of the most common manifestations of polycystic ovary syndrome is that a woman will have irregular periods. So we know that if a woman has her period once every 20 to 30 days, we call that regular bleeding. We could say with pretty much good certainty that she is ovulating, because if it takes about 2 weeks for the follicle to get recruited, ovulated, 2 weeks later she gets a bleed, if every 4 weeks or so she's getting a bleed, we know it must be because this is all kind of working pretty good. But if, let's say, she gets a period every 2 weeks and then she'll skip 3 months and then get a heavy bleed, well, what that tells me is that she's likely not ovulating. Like, this process of getting this follicle and this egg recruited and all of this, important interplays is not really happening, because what's happening when a woman has anovulatory bleeding is that, first of all, follicle's not getting recruited. She's not ovulating. There's likely estrogen, so in the beginning of the cycle, right, there's estrogen, and because she's not ovulating, she doesn't get that progesterone, and if she doesn't get that progesterone and then that release, we don't get the bleeding every month. And so with polycystic ovary syndrome, you may say, okay, but then why does she have bleeding at all? Well, the reason is because the estrogen is causing the lining to thicken, but then after a while, the lining either gets too thick or it kind of gets unstable because it's just been sitting around there for a while. So it sloughs off and it releases, but it's not because of any response to the progesterone or to the ovulation. It's just because an overgrowth of lining of the uterus. And that's also why women who have anovulatory bleeding, meaning they're just exposed to the estrogen, not the progesterone, those women are at increased risk for endometrial hyperplasia and endometrial cancer. And so that's one of the most important things we have to think about for women with polycystic ovary syndrome or anovulatory bleeding, is that we have to understand the risk of endometrial hyperplasia and endometrial cancer. And so oftentimes the treatment is progesterone or birth control pills, because birth control pills will have estrogen and progesterone, and it's the progesterone that's protective. So super, super important. You know, I often have women come to see me because, you know, they say, I have irregular periods, and one day I want to have a baby, and I say, okay, you know, great, you know, and let's say we diagnose polycystic ovary syndrome and alveolatory bleeding. I'll say, you know, I think at this point we need to put you on progesterone, because first and foremost, your health is important. And if you're not really ready to conceive right now, and there are other treatments we might want to do to help someone conceive who has an alveolatory bleeding, one of which would be to actually get them to ovulate, and we have medications to do that. But if they're not ready to get pregnant, I don't want someone just sitting around having irregular bleeding and unopposed estrogen, and therefore risk for endometrial hyperplasia and endometrial cancer. So one of the most important things I can do for that woman is put her on progesterone, or put her on a combined oral contraceptive that has progesterone to protect the endometrial lining, to protect the uterus. Okay, I think maybe I've gone on long enough. Maybe that some of that has spurred some questions. Why don't we see if there are any questions or comments or things I can answer? I think I would see the questions. So there are also, other things to think about with polycystic ovary syndrome. So the way that we make the diagnosis of polycystic ovary syndrome is having 2 out of 3 of the criteria we think about. So one is irregular bleeding, as I mentioned. That's kind of one of the hallmarks of polycystic ovary syndrome. Another is polycystic ovaries, so ovaries that have multiple follicles, multiple eggs that are multicystic, and some sort of elevated androgen. So whether that's clinical male pattern hair growth, or potentially elevated androgens, elevated hormones, male pattern hormones. And if a woman has 2 out of those 3 criteria, if there's no other explanation for the polycystic ovary syndrome, then essentially we say that she has polycystic ovary syndrome, and women with polycystic ovary syndrome are at increased risk for having a harder time losing weight, potentially obesity, potentially diabetes. And so it's really important that we kind of focus on getting them into a better weight range, so that, oftentimes just getting women in that weight range that's healthier actually gets them to start ovulating, and can sometimes even just fix the problem. And then potentially those women may not need progesterone or need birth control pills to regulate their cycles to give them protection of the uterus. Just losing the weight can do that. But the only, the hard part about polycystic ovary syndrome is that I often find that women with PCOS have a harder time losing weight. So it's kind of like a catch-22. It's super important for them to lose the weight, because they're at increased risk for some of the health issues related to being overweight. But it's also harder for these women to lose weight. So it's kind of a concern. In any case, I think the menstrual cycle is so incredibly fascinating. It's something that we often, refer back to and think about when we're doing an IVF cycle, or we're doing stimulation in either an oral medicated IUI cycle, right? So one of the, first line treatments for women with irregular menses or PCOS who are trying to conceive is, again, to try to get them to conceive, right? So then what do? We think about, okay, so the ovulatory cycle is not working. How do we get it to work? Well, one of the things we need to do is recruit a follicle, recruit an egg. And so using a medication like clomiphene citrate, like Clomid, or letrozole. So these are medications that a woman would take orally at the beginning of her menstrual cycle for about 5 days. those medications essentially tells the brain that there is not estrogen there. And so what happens is that the brain increases its production of FSH. So again, we go back to that, like this basic menstrual cycle physiology, right? So essentially, if the brain doesn't see the estrogen, then it's going to increase its production of FSH. And what does the FSH do? It recruits those follicles. So in a woman who is not recruiting follicles to ovulate, we can give them this medication that can recruit the follicles, recruit the eggs. Then what happens is we monitor the follicle development on ultrasound, and once we see a dominant follicle on ultrasound and blood work looks appropriate, we can have a woman take something called Ovidrel or HCG, or a medication that actually induces ovulation. And essentially what is that trying to replicate? It's trying to replicate this LH surge right here. And so what does that LH surge do, right? Normally in the brain, it's secreted by the brain, this hormone, and that essentially tells the ovary to release the egg. And that's what we're doing in a Clomid Ovidrel cycle. So the Clomid is recruiting the follicles, recruiting the dominant follicle, nurturing it to grow. When we clinically see that dominant follicle, we'll say, okay, we're ready. You're going to take your medication. We cause essentially an LH surge, not relying on the brain. We're having them take an injection to cause the LH surge, and that causes essentially the follicle to rupture, which is what ovulation is. It causes the egg to get released from the follicle, and then nature kind of takes its course a bit at that point. So then what happens is the fallopian tube will pick up the egg. The egg will migrate through the fallopian tube, and then we time it so that we either have the couple have intercourse at home, or they come into the office and we do an intrauterine insemination. And that's where we'll have the sperm specimen either produced that day or a frozen sperm specimen, take that sperm and then put it into the uterus through the cervix at the appropriate time. And then about 2 weeks later, we wait, and either implantation occurs and no period happens after that, and we have a positive pregnancy test, or there's no pregnancy test and usually a period would occur at that point. And so that's how kind of we manipulate what we know about the basic menstrual cycle to help to kind of tailor our fertility treatments. And so that's usually first line for someone who has an ovulatory bleeding if there's kind of no other issues. Of course, we want to check the fallopian tube, check the sperm, if there's a partner, and we just want to make sure that we were doing all that process with everything else intact. And IVF is also something that we use knowing the menstrual cycle very, very well, right? So what is IVF? So in vitro fertilization, again, it kind of goes back to this. So in an in vitro fertilization cycle, what we're doing is we're all of these follicles, all of these eggs that were sitting here at the beginning of the menstrual cycle that were that usually would have died off and only one would have gotten recruited, we essentially rescue all of these follicles, or as many follicles and as many eggs as we possibly can. So we make it much more efficient when we do an IVF cycle, and that we're not just dependent on one follicle, one egg, but as many follicles, as many eggs as we can. And how do we do that? Okay, well, we go back to what we know about basic physiology. We essentially have a woman inject herself with this FSH. Remember, this is the hormone that's secreted by the brain to normally recruit a follicle, to get that dominant follicle to grow. What do we want to do? We don't want just one, we want multiple. So what do we have her do? We have her take higher doses of FSH than she would ordinarily have in her body. So it's really pretty much like people say, oh, no, IVF can sometimes feel a little bit unnatural or iatrogenic, but it really is manipulating this natural process. Again, we're doing it at much higher doses, right? Because we don't want that one follicle, one egg to get recruited. We want multiple to get recruited. And so we have her take higher doses of the FSH. We essentially will give her also a medication, either Lupron or an antagonist. These are other special medications that we do in the IVF cycle to prevent the brain's production of these hormones, because we don't want the brain's hormones kind of interfering with this process. We want and we also don't want her eggs to ovulate, right? We want the eggs to get recruited and to grow in response to the FSH that we're having her take, but we're flatlining, we're essentially suppressing her own brain's hormones so that she doesn't ovulate those eggs. So that's basically what IVF is. She'll take injections at the FSH over the course of about 10 to 12 days. While she's taking those injections, she'll come in to see us for blood work and ultrasound to make sure we can see the follicles develop. And then once we see a good number of mature follicles, mature eggs, we'll have her take her final injection, which is essentially this LH surge, HCG often it replicates LH, so we have her take that, and then 35 to 36 hours later we go in and get the eggs, right? We want to actually go and get the eggs before they rupture, right? Because this is what's going to happen if we don't go in and get the eggs. That's why we're very careful about the timing of the injection before the egg retrieval, and that's essentially kind of where essentially the IVF process stops for the woman's body. At the next step, it all kind of takes place in the lab. So what ordinarily happens in the fallopian tube where the egg and the sperm meet, that part now happens in the lab, and then the embryos grow, and then once we have a healthy embryo, we can put that in the woman's uterus in potentially a separate cycle or in that cycle. But again, going back to the basic physiology, when we're either doing a medicated IUI cycle or an IVF cycle, we're always going back to the basic physiology and essentially manipulating it. And I think another important thing we want to talk about is female anatomy. So we talked a bit about the fallopian tube, the uterus, the ovaries. When we are evaluating a woman for infertility or for irregular cycles, we also have to think about structural issues, right? So there can be, structural issues at the level of the cervix, in the uterus. There can be fibroids and polyps. There can be obstructions in the fallopian tubes that may prevent the egg and the sperm from meeting due to prior surgeries or prior infections or potentially endometriosis. And so all these things need to be evaluated when a woman comes in. And super important in terms of women's health, women's reproductive health, and fertility. I encourage questions if there are any. I think you can write it in the chat. So I think the question should be able to show up. If there are no questions, I'm going to encourage you to reach out after. I think our contact information is visible to everybody, so I encourage people to reach out, potentially make a consultation. Happy to answer any questions. Let me just see, make sure I'm not missing where the questions might show up. Let me see. Oh, somebody requested to be in the live, so okay. Okay, here's a question. Okay, how much does everything change for a woman in her 40s that still gets a period? Okay, so this is a great question. So how much does everything change for a woman in her 40s that still gets periods? Is the chance of getting pregnant pretty slim? So great question. Thank you for bringing that up. So there's a number of things that affect fertility, and we all know age is one of them. But why is age one of the main things that affect fertility? So it's important to recognize that women are born with all of the eggs that we will ever have. And as we get older, we lose those eggs through a natural process of cell loss. So yes, we're ovulating eggs, but even if we're on birth control pills our whole lives, we're still losing eggs through a process called atresia, so a natural process of cell loss. And so with less egg number, that poses a potential issue, a challenge for fertility. Also, the eggs in our body undergo chromosomal changes. So as the eggs are sitting in our ovary, they're kind of frozen in meiosis, and as the chromosomes in the eggs are sitting there, they can sometimes get sticky, is sort of the idea over time. And so when meiosis resumes and they sort of, during ovulation and then at fertilization, the eggs don't do the chromosomes in the eggs don't do such a good job of separating easily. And so eggs are more likely to have an the wrong number of chromosomes. You're supposed to have ultimately 23 in your egg and then 23 from the sperm. But if you have 24 or 25 or 20 or 21, when it meets up with the sperm, the resulting embryo is not going to have the correct number of chromosomes. And when an embryo doesn't have the correct number of chromosomes, the most likely outcome is first of all, no pregnancy. So that embryo is unlikely to divide, and therefore unlikely to implant. And so just may not get pregnant even if an egg fertilized. Also, the eggs may not fertilize if they're chromosomally abnormal. There can also be early miscarriage or miscarriage in general, and then also a higher rate of chromosomal abnormalities in the embryos or in the pregnancies. So those are the kind of the main challenges in women as they get older. I wouldn't say that there is, and that's just sort of like a gradual change over time. I wouldn't say there's one particular age, that all of a sudden changes, but we do kind of see the graph when we look at it in terms of the chance of pregnancy really diminish in a woman's late 30s, early 40s, and chance of miscarriage and chance of chromosomal abnormalities really does go up. But what we usually say is that if a woman is over the age of 35 and let's say she gets a period once a month, first of all, I will tell you that's a very reassuring thing. So if a woman gets a period once a month, we know that she's ovulating. And we know that she's releasing an egg. But again, going back to what we were talking about, that's not the only important thing. It's also, is she releasing a normal egg? And what we do say is that if a woman is over the age of 35 and it's been taken, it's 6 months, and she hasn't been able to conceive on her own, then we have to think about potential intervention, because we don't want a whole year to go by as we're really dealing with very, very precious time when it comes to infertility, because we can say, oh, let's wait, a few months more, but then time adds up, and 42 is going to be a lot harder to conceive than at age 39. And that's for any given woman, right? So women in general, when you compare women to women, they'll be different in terms of their particular fertility. But one woman at the age of 39 is going to have an easier time getting pregnant than at the age of 42, and that's just because by definition, as she gets older, she'll have less eggs and less chromosomally normal eggs. And so we just have to be sensitive to that and cognizant of that. And when a woman comes to see me and she's in her 40s and she's having trouble getting pregnant, we don't want to sound the alarms, but I will tell you that we don't really want to wait. We really want to delve, pretty quickly into figuring out, is there something wrong with the fallopian tubes? What's going on with the sperm? What's going on with the hormones? Checking her thyroid, checking her prolactin, checking all of these things. And then also making sure she's ovulating, doing ovarian reserve testing, looking at her follicles, looking at her AMH. Now, I will tell you, though, even though everything may check off and seem quote-unquote normal, right, or kind of no red flags, the concern still is that a woman in her early 40s who has been trying to conceive, hasn't been able to conceive. I would say she should pretty quickly move on to the most effective treatment we have, which would be in vitro fertilization. And it doesn't have to be, it's always a conversation, and some people want to just still monitor and they want to do inseminations, but I talk pretty in depth in my consultations about, well, okay, what is the success rate of you conceiving at this point if you were to try on your own continuously, or an insemination, or IVF. And I think once people hear that, if they say, I want to do X, Y, or Z, I think that's fine, but I think it's important to kind of talk about it so that people can make an informed decision. IVF is the most effective treatment we have. The issue with IVF, though, is that it's not, as women get older, not only do they have a harder time getting pregnant on their own, but they also have a harder time getting pregnant with IVF. Because IVF is only as good as the embryos that come from that cycle. So, IVF is great because we can get lots of eggs in one treatment cycle, hopefully, a number of embryos. The embryos then can be tested to make sure that they're chromosomally normal. But in the end, if all of the embryos that we get are chromosomally abnormal, well, then we really have nothing to transfer into that woman's uterus. And we know that as women get older, the embryos that they make are more likely to be chromosomally abnormal. And so that's why it's just important to think about in terms of moving forward. In terms of exact numbers, we'd always go over it based on the particular woman's age and what the situation is. But I will tell you, I mean, a lot of women I see are in their 40s, and it's a matter of kind of figuring out, what are the options and what is the best course of action given the history and all of the things that were done up until that point. Okay, so hopefully I answered that question. Let's see. Hormone replacement therapy. So someone's asking about hormone replacement therapy, HRT. Does it remedy PCOS? So, and then if so, how long before it begins to help? Will this approach help prepare a woman for reproductive health? So, I mean, essentially, hormone replacement therapy, which is incredibly important. We usually think of that as something for women who are perimenopausal or menopausal, not for the purpose of trying to get them pregnant. And remember, even treating a young woman with polycystic ovary syndrome who's not on HRT, but is essentially taking medication like progesterone to protect her uterus, that's not fertility treatment either. Fertility treatment is clear fertility treatment. So fertility treatment is essentially something like an oral medication like Clomid or with an intrauterine insemination or timed intercourse or in vitro fertilization, multiple different protocols for in vitro fertilization, different medication protocols. But essentially, when we say hormone replacement therapy, that's usually something we think about for a supplemental therapy for women who are perimenopausal or menopausal. It's not really for polycystic ovary syndrome per se, who essentially want to take something, for women with PCOS who in those situations we want to have them take progesterone particularly to protect their uterus. And neither are the fertility treatments. So fertility treatments are processes where essentially, the end product is that there may be higher levels of estrogen, like in an IVF cycle or in a Clomid cycle. But those are kind of temporary elevations in estrogen and not really connected to HRT. Hope I answered that question. Okay, so is there any specific test that can be taken to figure out the egg count or quality of the eggs before the IVF process? Okay, amazing question. So yes and no. So there's a lot that we assess, right? I kind of alluded to a bunch of things like fallopian tube, sperm, like overall health, right? Like there's so many things we need to think about. But ovarian reserve is huge. That's one of the most important factors in terms of understanding a woman's infertility and also understanding what we think we might yield when we do an IVF cycle or any sort of treatment. So one of the ways we can assess ovarian reserve is by looking at the follicles. So those are the pockets of fluid in the microscopic egg. We usually can do an ultrasound, see if I have a picture. I don't think so. Anyway, essentially what we do is we do an ultrasound where we look at the follicles, we look at the pockets of fluid on the ovary, and that every follicle represents basically a little house, so to speak, for that microscopic egg. And so the more follicles there are at any particular time, the more eggs there are recruited or available at any particular time, and that's a representation of the number of resting follicles a woman has in her ovary. So if a woman has a very low ovarian reserve, a very low resting egg supply, the number of follicles, the number of eggs that will be apparent at any given point in time will be low. If she has a high resting egg count, then the number of follicles, number of eggs that are apparent on ultrasound will be high. And so we get some sort of sense based on doing an ultrasound. The best time to do that ultrasound is at the beginning of the menstrual cycle. We usually call it an antral follicle count. The reason why it's the best time to do an ultrasound is because we don't have recruitment of a follicle yet. So we don't have that dominant follicle that's getting in the way of the other follicles. So that's why it's the best time to see all the little follicles that are kind of sitting there waiting to get recruited. That's why we usually say reach out with the beginning of your period, days 1 to 3, because that's when we'll usually be able to see the follicle count. And so that's important. There's also an FSH test. So FSH traditionally was the hormone that we'd always look at for assessing ovarian reserve. So the ovaries produce estrogen. The more follicles there are, the more cells there are that are producing the estrogen. That estrogen feeds back on the FSH to tell the brain, feeds back on the brain to tell the brain, okay, don't produce so much FSH. The FSH is the hormone that is stimulating the follicles, that's stimulating the eggs. And so when there's a high number of follicles, a high number of eggs, a good amount of estrogen, a healthy amount of estrogen, that feeds back on the brain to lower the FSH. When there aren't that many follicles, aren't that many eggs, not that much estrogen, what happens is you don't have that feedback, and so then the brain has higher FSH levels. The issue is, and so basically what we'd always said is, well, if you have a higher FSH, like, 10, 11, above 11, then we say, okay, that's representative of a low ovarian reserve, a lower egg supply. But the issue with FSH is that it has to be done at the beginning of the menstrual cycle. You can't be on birth control pills. There's sort of limitations. It actually, if you have a low level, it doesn't actually mean everything is good. It only means something if you have a high level, because if you have a high level, then you have lower ovarian reserve, but FSH levels can fluctuate, so it traditionally hasn't always been the best test. AMH is a much better test. It's more reliable. It tells you a lot more. AMH doesn't have to be done at any particular time of the cycle. A low AMH represents a low ovarian reserve, a low follicle count, and a high AMH represents a higher. So in connection between an ultrasound, a follicle count, and an AMH, we can get a sense of a woman's ovarian reserve. Now, the question also asked me about quality. There is no really good test to tell us about a woman's egg quality. When we talk about quality, the thing that I alluded to before were about the chromosomes in the eggs, right? Normal chromosomes in the eggs result in more likely to be normal chromosomes in the embryo, and that's what we're after. As women age, they have a higher chance of having chromosomally abnormal eggs. So we can actually we use predictive models to say, okay, based on your age, your chance of having a chromosomally, normal embryo is this, or whatever it is based on the woman's age. But there isn't really a test to tell me whether the eggs in your ovaries have a normal number of chromosomes or not. So that's why it often comes down to, if we do an IVF cycle, it often comes down to being a numbers game. The more follicles, the more eggs, the more embryos, the more likely we are to get a normal embryo. The chance of any one embryo being for normal or not depends on a given woman's age. So I hope that makes sense. Okay, there have been a number of questions that came up as I was answering that one. So let me just go up. We did that. The quality we talked about. I thought more came up, but maybe not. I think we're at the end of the questions. So I hope that made sense. I hope I answered a lot of the questions. I mean, these were all amazing questions, and I will tell you that each one of these, I feel like we can take down different roads and sort of answer multiple aspects related to it. And so I invite you to reach out, continue to ask your questions. So happy that you tuned in today. Women's health, women's reproductive health is so incredibly important. Good. I'm glad that helped. Thank you. And thank you for tuning in, and have a wonderful day, and happy May. Okay, take care. Bye-bye.